you're walking by and someone's like, I'm doing my Kegels, and you can see their shoulders moving and they're like, their body, I'm doing my Kegels, and they're like, bouncing on their chair. Yes. Like, nah, homie, you're not doing it right.
Dear Shandy. Welcome back to Dear Shandy, listeners. Hello, Andy.
Hello. You're looking divine today.
Oh, sweet husband.
I like the dark lipstick.
This isn't dark lipstick. This is just red lipstick.
Dark.
Okay. We are joined by a very exciting guest today.
Yes.
Today's guest was suggested to us by a Shandy.
Mm-hmm.
A listener wrote me an email, and then I did a little digging, and I was like, she's correct. This would be a fantastic guest.
I remember the conversation.
Yes. We are joined today by a sex-positive pelvic health physical therapist, sex educator and counselor, and professor at Dell Medical School in Austin, Texas. Correct me if I'm wrong on anything, but I'm pretty sure I got that right.
You got it perfect. You got it perfect.
It's honestly, you have so many credentials that it's hard to keep track.
That's a long one.
It is a long one.
It's a mouthful. Okay. You are, correct me if I'm wrong again, but this blew my mind. One of 3 pelvic health physical therapists in the world to also be certified in sexuality counseling. Am I correct?
Yes. So that's actually, that number is going up. So I think now it's about 6 or 7.
Oh, well, okay. No big deal anymore.
Right?
And she's also the founder of sex ed platform UC Logic, which I have been enjoying very much. Very educational, very woke. And you talk about things that I feel like just people are afraid to talk about. I'm not going to talk about your credentials anymore. Just join us. Dr. Uchenna Ossai, thank you so much for joining us today.
Thank you.
Thank you. Thank you so much for having me. Like I said, I'm just so excited to gab and talk about all the things, sexy or not, or things going down in the pelvis.
Yes.
Whatever floats your boat.
Yeah.
Pelvic happenings.
Yes.
So I've got to say, Uchenna, that when we polled our listeners, because we always, whenever we have a guest coming on, we ask our listeners to ask their questions. I don't want to assume what people want to know, and I want them to tell me what they want to know. Right. The response to hearing that we had a pelvic floor physical therapist on was overwhelming.
Whoa.
Yes. And we've had a sex therapist on. We've had a marriage and family therapist on. We've had lots of experts, but it was like overwhelming. Mm-hmm. And it made me realize just how desperate people are to talk about this.
Yep, that sounds about right.
This jives with your experience.
1,000%. 1,000. People of all genders, primarily, yes, but primarily with women and vagina owners and all that.
Okay. Okay, so typically with these Hot Topics episodes, we divide things into confessions and questions for you, so as an expert. And it's always been interesting for us to see what people respond to because, for example, the sex therapist, there were a lot of questions for confessions, like what has she seen? What's the weirdest kink she's ever encountered? But for you, it really mostly fell into the for the doctor territory. People want to know about their pelvises.
Mm-hmm.
Heck yes. I mean, I love that you had so many people asking questions. I mean, that makes me super duper happy and I'm jumping with joy. But it also makes me sad because it says that there's not a lot of information and resources out there for people to easily access. But then also kudos to you both for bringing this to everyone's table.
So on that topic, right off the bat, I'm going to go out of order because one of my questions was, is it just me or does it feel like this isn't covered at all anywhere?
It's not. And I can tell you this from many layers, right? So when I went to physical therapy or when I went to PT school, I became a physical therapist to do pelvic health. It wasn't something I fell upon. Like I knew I wanted to do this when I was 15. And It was really difficult to find graduate programs that had even professors with experience in teaching this. So then I realized, I need to do a residency program, so postdoctoral training. But at the time, there were only 6 in the country that were credentialed that took one resident at a time. So it was crazy competitive. I was very lucky in that I got into the Duke program and the WashU program. I ended up going to WashU. But then on top of that, so I did a residency, but then in the residency program, they weren't really doing a lot on sex, even though we were seeing people with sexual dysfunction. And I am going to brag. I went to the best program in the world. I had the best mentors, advisors, all of that, educators. But I mean, even my advisor said to me, you know what, you see, like, you're going to have to do some self-study here because we don't have this specialty here. And so I had to then do additional training at University of Michigan, where I got didactic learning. Because here's the thing, you know, I was practicing for a couple of years, you know, in Houston, which was a massive medical center. And I was in a multidisciplinary practice, which is ideal when you're dealing with pelvic floor dysfunction, you know, but I needed to practice to understand what I was talking about. And I, you know, yes, I'm comfortable with, or at least I thought before I did the Michigan program, that I was comfortable talking about sexy time until I went through formal training and I got the didactics and I got the certification because I wanted my patients to know that they weren't talking to someone where it was just, you know, I read a book and now I'm going to counsel you. It's like, no, I went through training. I went through a lot of supervision with all these senior therapists to make sure that I knew what I was doing and doing the right thing. And that's why that's why you're seeing so few pelvic health PTs with this certification. Okay. You're seeing a lot of pelvic health therapists out there, but then when it comes to just talking about sex specifically, that's also another niche.
That's actually crazy because you would think that that would naturally
be most of it.
Yeah, that they would go hand in hand.
Mm-hmm.
Because sexual health is health. If a patient does not view themselves as having a sex life that they deem adequate, they are not going to view themselves as healthy.
Yes.
So it is an indicator of health. It's an indicator of health. And you have to ask patients about that. If you're not asking a patient about their sexual function, then you're not doing a proper screening.
I'm going to start with confessions, of which there are very few questions, just a couple, and then we're going to start talking about the pelvis. Mm-hmm. What, in your experience, are the 3 most common issues that patients come to you for?
Oh, okay. Urinary incontinence.
Okay.
Pelvic pain, and some type of orgasm dysfunction or libido dysfunction.
Okay.
I'm going to lump those together.
Yeah. Mm-hmm. No, that's actually, and honestly, that really tracks with the questions we got.
Yeah.
Like there were a couple of outliers, but I really try to focus on the most frequently asked ones, and that it tracks.
Yep.
And then what has been the most surprising thing you've learned or seen in your line of work?
Shame has a lot to do with how people experience their pelvic floor dysfunction. Shame about their body, understand how they were educated about their body, audacity, autonomy, a lot of the things that how we were raised, how we were taught to experience the world, and particularly our bodies in that world, can impact how we experience pain or how we deal with pelvic floor dysfunction. So I was actually surprised at how closely those were interlinked in all the years that I've been practicing.
Mm-hmm. Once again, her answer tracks.
Yeah.
With the questions we got.
Did you find that the shame fell more on the male side or the female side?
You know, I think it's an equal opportunity employer.
Mm-hmm. Yeah.
You know, I think it's one of those things where because, you know, when I was in Houston, I saw actually like 50, almost 60% men or male identified individuals. And the shame was legit. It was real, you know, no matter what we were dealing with, whether it was post-prostatectomy incontinence and ED issues or just premature ejaculation, all of that. And then for women, it was the shame took a different, you know, shade.
Yeah.
But it was still there. And a lot of my time was spent kind of talking them through that.
Right.
And then we were able to kind of get into the nitty gritty, the techniques. But when you have that shame and you have that, it kind of serves as a block.
Mm-hmm. And what was your go-to method of, you know, sort of like the 90 seconds, stop the shame talk?
Yeah. So the go-to method was to acknowledge that the shame was there.
Uh-huh.
You know, to kind of pull it out, say, okay, well, that's a manifestation of shame.
Mm-hmm.
And I'm going to manage your shame by giving you some education on that specific issue. Okay. And then tasking you and kind of pinning that to the homework assignments I would give them.
Right.
So it wasn't just do Kegels. It might have been do Kegels and belly breathing, but then I want you to listen to this 5-minute or watch this 5-minute YouTube video on penis function.
Sure. Those are my favorite videos.
It actually got me thinking about just how powerful an emotion shame is.
Mm-hmm.
Like, we've actually talked about this in a completely different context. The context was therapy.
Yeah.
Right.
Like talk therapy, but it's just amazing how shame is just like
Such a driver.
Yeah.
Like especially shame that, it sort of develops in early childhood and then it just drives so many life choices and so many sort of micro choices. It's a
And
powerful
hang-ups.
emotion.
It is.
Especially with sexual dysfunction.
Yeah.
Yes.
Okay. Questions for the doc. We have quite a few. And like I said, I was almost emotional reading some of these. All our questions are always anonymous, and a lot of the questions came along with some form of, I can't believe I'm sending this to a stranger, but
Lay it on me. Lay it on me. I love it.
So we're going to just start with the basics.
Okay.
Because I feel like you hear about the pelvic floor here and there in a vague way, like maybe in an online article about sexual health. But can you clarify what exactly it does and the connection between pelvic health and sexual health?
Absolutely. So think of your pelvic floor as, almost like a multi-layer hammock of muscles that sit at the bottom of your pelvis. So they hold your organs inside of you. They attach at your pubic bone in the front, right? And then all the way back to your tailbone, your coccyx bone in the back. And its primary job is to stabilize your spine, hip, and pelvis, to keep your organs inside, but then also helps you with urination, defecation, sexy time, and babies. And so basically it's a skeletal muscle. So meaning you have control over that. So for example, you don't have direct control over your bladder because that's smooth muscle. So that just kind of runs on autopilot. Whereas your pelvic floor muscles, you can contract, you can relax them, and you can lengthen them. And that's really important for people to understand. They're supposed to be contracted, relaxed, and lengthened. So they need to go through all those ranges, right? Just like you can bend your elbow and straighten it, and it can go through that range. Your muscle has to do that. If everyone's always concerned about clenching their pelvic floor all the time, then we have a problem. Then you have problems with pain or incomplete emptying or urgency frequency. And so that's how it's connected. And it's also a synergist with your diaphragm. So when you inhale, your diaphragm drops down and your pelvic floor should release and drop down as well, right? It works with your abs, your glutes, everything. So training your pelvic floor means training everything.
So it's just a question.
I already have questions.
I'm trying to feel what you're talking about. But like, if you have to pee really badly and you're holding it in, I'm assuming you're contracting your pelvic floor. Okay.
Yes. But imagine if you were clenching all day, right?
Oh yeah.
Right.
Wow.
And that's your baseline.
I can't stop clenching now.
It's terrible.
Right. Imagine that's your baseline all day, and you're not aware.
Relaxed.
And you're not aware that you're clenched.
Yeah.
That's the trick. So that's why it's difficult to treat sometimes, because first you have to get the patient to recognize that their muscle is actually in a hypertonic state or the opposite.
Yeah, they don't know what default is, like what just natural is.
Yeah. Wow. Right. So just one other question. So when you're orgasming, is that a deep contraction and then release of the pelvic floor?
Yes. So basically it's almost, it's like the pelvic floor is contracting, relaxing in quick rhythmic waves.
Okay. And that's passive. Like you're not actively doing any of that. That's completely that's reflexive.
Exactly. Okay. Yeah, that's kind of like automatic or, part of that autonomic parasympathetic nervous system, which is a whole other conversation. Mm-hmm. But again, like if you don't have normal pelvic floor function, so if you have low tone, high tone, if you don't have the coordination, right? So if you're relaxing when you think you're contracting and you're contracting when you think you're relaxing, that's going to disrupt your muscle pump system during orgasm, which can impact your ability to feel and experience the orgasm from a physical aspect, from the physical side.
Can you define quickly low tone and high tone?
Yeah.
Yes, absolutely. So everyone, let's just all do an experiment. Everyone clench your fists, right? So just clench your fists really hard. And so you feel that's high tone. So if you feel your fist and the muscles in your hand, that's a high tone. Mm-hmm. And then like if you relax and like kind of let everything go limp, that's low tone.
Okay. Okay.
Easy enough?
Yeah, that's easy enough. I like that. And when you say lengthen, we haven't even gotten into the questions. We already have so many questions.
We're going to get stuck here.
I know. When you say lengthen, is that the same as stretching? Like if I'm to flex my bicep or clench my bicep versus stretching it, or is it just
relaxing? Is it just relaxing?
Expanding it. Do you know what I mean? Like
yes. Yes. So think about it when you contract, like let's say you're doing a crunch, right? And you're thinking about your abdominals. Your abdominals are shrinking. They're getting the rectus abdominis muscle gets shrunk down. So that's what we call like concentric contraction. So the muscle shortens, right? But you can still do a contraction as the muscle is lengthening. And so your muscle relaxation and lengthening are not the same thing.
Okay.
And so basically if you're having a bowel movement and your muscles are like dropping down, like that's you're lengthening those muscles.
I think I may have had an involuntary lengthening once at Taco Bell. Is that a thing that actually, that's just how it happens, right?
Especially if you get that fiery hot sauce, that involuntary lengthening is going to be a thing.
It's a very, very solid lengthening I had.
Yeah.
We interrupt this program to discuss a product that we use on the regular and have for years, actually.
Well before I met you, I was using HelloFresh.
I just don't love grocery shopping, meal planning. It's just not my thing. I wish I were more like that. I wish I were better at it.
I think you're in the majority. I think most people don't like planning and shopping for meals.
Yeah, I actually don't mind the act of cooking.
Right.
And that's why this is perfect. I just like having everything on hand, knowing that it's all there, and then I can cook.
Yes.
I don't mind that. But it's like, oh, damn it, I needed scallions for this dish. Now do I have to go out and buy scallions or just figure it out?
Right.
So I love meal delivery kits, and I think HelloFresh is pretty rock solid.
Solid. It combines the good, like doesn't try to be too fancy.
Yes.
Some of them try too fancy.
Yes.
Like just give me what I want right in the bullseye and make it easy.
Yep.
They make it easy. They give you what you want. Can't ask for more.
Yes. They offer 27 plus recipes to choose from. And also, we don't eat meat. We are pescatarian, and we always have options.
Always. Never run out. And it's always very fresh. I mean, as the name would suggest.
Yes. Also, it's 28% cheaper than shopping at your grocery store.
That's a big deal.
And
especially nowadays.
And 72% cheaper than eating out. Go to hellofresh.com/shandy12 and use the code shandy12 to get 12 free meals, including free shipping.
Go to hellofresh.com/shandy12 and use code shandy12 for 12 free meals. It's a lot of meals.
There's a lot of meals.
It's a lot of meals.
It's actually like a freakish, like what's the catch?
Yeah, and that's not 12, that's 12 meals for two.
Yeah.
And free shipping.
I'm just going to get right into it.
Get into it, my friend.
You know what I'm going to say now. I knew vaginismus was a thing. I knew it existed. But I was really, truly overwhelmed by just how often this came up from our listeners. Could you give us a brief overview of the condition and how you would, just the bare bones of how you would treat it? And then I have sub questions after that.
Yeah, absolutely. So vaginismus is one of the conditions under the pelvic. So I'm going to nerd out for a second, but I do think it's important for your listeners to understand it from this perspective as well. So the DSM-5 categorizes, women's sexual dysfunction in different categories. One of the names for it is genital penetration pain disorder, genital pelvic penetration pain disorder, GPPPD.
And it really rolls off the tongue, that one.
It really does. And vaginismus is under that umbrella. So vaginismus is a type of sexual pain. And so what happens is the muscles, basically like the outer third muscle, so the entrance of the vagina is going to kind of close or contract around a penis, tampon, speculum, finger, toy, whatever. And just reflexively does that. Now, you might see it in terms, it's rare that we have a patient that you put it there and it just clamps down. What we commonly see are patients where it's just tight no matter what, and we can't get our finger or we can't get a speculum or even a cotton swab in there. So that's specific vaginismus. Okay. Some of your listeners may also have something where they may be able to get something in there, but it's painful and it feels really tight, or it just feels like someone's like 1,000 razor blades in their vagina every time they have penetrative intercourse. And for some patients, it's even so bad that arousal. So them just thinking about sex elicits pain in the clitoris, in the vaginal opening. So it's incredibly disruptive to someone's life, well-being, self-esteem, and think about it, if this is a thing and you don't know how to treat it, or your doctor doesn't know how to treat it or triage you properly, and then you keep having sex because you're wanting to make your partner happy, or you're just thinking that it'll go away eventually, over time, your brain thinks that sex or penetrative sex or any type of sex is dangerous. So then your body starts to get this fear response anytime the thought or idea of sex comes into play. So to answer your question about how to treat it, it just depends on what degree is coming to my clinic. If this is something that just started for this patient a couple months ago and they're like, I don't know what's going on, then I'm just going to say, okay, so let's just do an evaluation. So we'll do a pelvic floor assessment, see what's going on. And I'm going to ask them, what's going on with your back, spine, hips? I'm going to do a full screen. So I just don't go straight to the pelvis. Because remember, when I talked about the pelvic floor is part of a system, right? So sometimes someone might be having a back issue or a hip issue that's referring to the vagina and penis, right? And so that can cause problems. So if we just treat that, everything goes away in the genital area.
Oh, wow. Okay.
So that's why you really do need a therapist that understands that and is going to screen that first instead of just going to the pelvis. So that's going to be, they have to do their due diligence with that. Then once I screen them for that and they're like, everything's okay, then if there's a fear component to it, then I need to bring in mental health, or I need to kind of start to break this down for them and help them understand, okay, now we're dealing with a chronic pain issue, right? Especially if it's been longer than 6 months. Because now your brain is invested in keeping this pain cycle. So we have to first get you to understand they have a chronic pain issue. We might need to give you something like lidocaine. We might use dilators to help massage the muscles and release the muscles, stretch the muscles. But it's not just stretching the muscles, because it's the idea of sex that gets that person to contract. So we have to do almost like graded exposure therapy for them. So for some of our patients, they might do dilators on their own, but they don't know how to do that for themselves. And so they're just kind of re-traumatizing themselves when they do it by themselves. So sometimes I might even do dilator mindfulness, where I teach them to just be mindful, even think about, just go through that process in their brain, don't touch their bodies. Or start when they're ready to touch their bodies, we start with inner thighs, we start with belly, we start with breasts. We kind of get their body, kind of soothe your body down, so that when your partner touches your shoulder, you're not going to have this reaction like, holy Jesus, I don't want to do this.
Yeah.
Oh, you know what I'm saying?
It sounds like you're describing a mental reaction to a physical symptom.
Yes.
So my question is the original God, how do you say it again?
Vaginismus. Yeah.
Oh, it sounds like a monster in a Godzilla movie or something.
It does.
Really like Godzilla versus Vaginismus. It works. It works.
It really does work.
It works. Yeah. So is the original cause of the vaginismus mental or physical?
It depends. Okay. So for some of our patients, it could be a history of trauma. For some of our patients, it's a back surgery. For some of our patients, it's a vaginal delivery or C-section. For some of our patients, it's a combination of they were born with a sensitive nervous system, right? And they might have endometriosis or vulvodynia, which is a whole other condition where you have burning at the vulva, the introitus in the vagina all the time, or some of the time anyway. So it might just be, they might have a really stressful event, right? Like they may have taken their SATs and they didn't go well, or they went through a divorce. And then that event kind of was the straw. And then their body just kind of had this reaction.
So sorry to try to simplify this, but would you say that the majority of cases stem from a mental or a physical origin?
Yeah, in your experience.
In my experience, it's 50-50.
Wow. Oh. Okay. So in other words, there are probably half the cases are a result, if not more, of a mental origin followed by sort of a mental like a loop cycle where it just keeps.
But I want us to like think about it more comprehensively. So I would think of it as a chronic versus acute condition versus like mental versus physical, because mental health is physical health. And so if your body has a reaction to something going inside of it, right, then it's not, yes, like it might just be that there's a nerve that was compressed when you had a fall, or when you gave birth, like, you know, you had vaginal muscle tearing, and that scar tissue has caused of that, you know, that can happen. But then if you have that enough, so let's say you're it's almost like constantly like drinking lemonade when you have canker sores in your mouth. Over time, you're just not gonna want to drink anything.
Right.
Yeah.
Right.
And so that's really just you protecting yourself. So there's nothing dysfunctional about you not wanting to drink anything if you have canker sores in your mouth.
Yeah.
And so
that's a good comparison.
Does that make sense? So because a lot of patients really are like, something's wrong with me if I was just more relaxed. And it's not that simple. Like if it was just about drinking wine and like, you know, taking an edible, I mean, dang, I'd be out of business.
Yeah.
You know, I want to be out of business.
You could do that anyway, even
right?
if it doesn't work.
I mean, please, like, don't let me stop you, right? But yeah, I think that there is not. I wish I could say there was a simple answer as to why this happens. I think the important thing and the positive Pollyanna spin on this is that we are talking about this, and that people are going to they're going to understand, oh, okay, so I can get help for this. And they're going to have audacity to pursue interventions or a healthcare provider that's going to listen to them and is going to properly address this issue for them so that they can get to a place where sex is no longer a place of stress and despair.
I have what might be a really stupid question.
No stupid questions here.
I might cut this based on how stupid I'm worried it is.
What? Don't know.
But
she's Canadian. I'll listen to her.
I'm apologizing for my question before I've even asked it. But I'm trying to understand where sexual arousal meets that the contraction, like the inability to let anything in. Can someone be sexually aroused and also have that sensation where they can't let anything in? Does that make sense?
Yes. And that's a
good
great question. That's a great question.
Thank you.
Yes.
You're stupid to think it was a stupid question.
Yes. Yes, absolutely. I have patients. A lot of people are very smart about figuring out other ways to have a sex life that doesn't involve penetration. And so they can get aroused. They can have orgasms. You don't need a penetration to have pleasure. We all know this. But like, it doesn't disrupt, like you can still be aroused and not, and have that response.
So you can be aroused and be wet and still, wow.
Yep.
It actually is, it's almost impressive how strong those muscles are.
Yes.
Like it's for better or for worse. Like that's kind of amazing.
It's, and the thing is, you know, it's one of those things where when I work with patients who have, and also there's a primary vaginismus and a secondary vaginismus. So, or a primary issue versus secondary. So primary is basically, these are individuals who've had this problem from like day one. So from the start of their menses, they never were able to insert a tampon, never been able to have a pelvic exam. So we see that a lot.
Okay. And
that's actually much harder to treat than the people who were having penetrative sex, but then something happened. And then we have to kind of get them there, because the difference between the secondary and primary is that the secondary has experience with pain-free penetrative intercourse, whereas the primary patient does not.
I just want to circle back slightly then. So when you said the treatment, would you say that using dilators is the most, I mean, it sounds like it's a combination of the mental health, but physically dilators are quite common?
So dilators are quite common. Some people can do dilators without aid, meaning they can do dilators without medical aid. So I think I mentioned lidocaine. So lidocaine cream is a numbing. Obviously, we all know what it does for our teeth when we get dental work, but we can put that at the vaginal opening to numb it a little bit so that you don't have that sharp acute pain when you insert a dilator. So for some people that can be helpful, because even just the feeling of pain shuts them down. Mm-hmm. And then, of course, we have to get patients to get into a pain acceptance model. Because I tell people this, and this is one of my, as you all have realized, I like analogies, metaphors, all of that.
I tell
people
You're
that
in good company.
You are in good company.
I tell people that they need to think of their pain as Liza Minnelli, right? Always like center stage, just like, I'm here, dancing all around. You don't notice anything else on the stage but Liza. That is your pain. And we need to get your pain to we need to get Liza's, AKA your pain, to share the stage with other sensations, with other experiences that you're feeling, including that pain.
Okay. With the backup singers.
Yeah.
With the backup
instrumentalists.
singers, right?
The band.
Right?
Okay.
And so having that pain acceptance concept is really hard for people. But once they get there, once they can, and that's where mindfulness techniques are really helpful. So that people can feel, okay, I have pain, but I'm also feeling open. I'm also feeling warm, very basic things, but it's super helpful.
So let's say someone comes to you with vaginismus and they go through treatment and it's successful. And then they go about their life. Does that pain ever fully go away, after successful treatment? Or when you say it shares the stage?
Yeah, it depends. So, for some of our patients, for example, some of our secondary patients, the pain does go away. I see that all the time. With our primary patients, we see that it does go away, but for some, it just may be instead of it being a 10 out of 10, it's a 1 out of 10 or a 2 out of 10 every once in a while. But with the goal...
I feel like that's pretty good. From a 10 out of 10.
Absolutely. Because with the goal of it kind of over time, I tell my patients, I'm not looking for perfection. I don't discharge patients when they're 100%. I discharge them when they say they've seen 70% improvement. Because at that point, they can carry it on their own. Mm-hmm. Right? They don't need me at that point because they already have the tools. I don't want them to see me forever for the rest of their life.
Okay. So another very common question, I'm sure this will track with your experience. And getting back to shame and guilt, the lack of general awareness around, and you're making me realize it's not just vaginismus. Vaginismus is one condition under this umbrella. I forget what
GPPPD.
You forgot already?
Girl.
I'm really slow today. So the questions are sort of, all similar. How would you, I'll start with this one. How and when would you recommend someone disclosing this condition or a condition like this with a new partner? Because this came up a lot.
Yeah, immediately. Well, let me say this. With that caveat, I say when you feel comfortable, but that may be never, so I always say the sooner the better. But make sure you understand the condition or what's going on with you first, and you're in a good place with it. Meaning you understand that it's something, or you're working on getting treatment, or you're taking a break from treatment, wherever you're at, make sure you're just in a good space. The new partner should not dictate how you feel about what's going on in your body.
Got it.
It's more when you're having a conversation about pleasure and negotiating your sexual experience, sexual scene with your partner, you want to make sure that you're kind of centering it around, this is what gives me pleasure. And this is what doesn't give me pleasure. And depending on the day, the thing that I told you gives me pleasure might not be. So you might just need to check in. It's about a conversation, because when I've had a few partners with pelvic pain, male partners with pelvic pain, and it's been easy breezy for us, obviously because I do what I do, so they hit the jackpot with that. But but also because it wasn't that I was, quote, willing to go along with them. It was more that I was very much interested in having a mutual, pleasurable sexual experience, and I wanted to engage with them in a way that was pleasurable for them and pleasurable for me. Does that make sense? Mm-hmm. So if they center the conversation around that, I would say they should just talk about it as soon as possible. Most probably, I would recommend before their first sexual encounter with that person, so that they don't set up that sexual experience to kind of be where they're performing or they feel like they need to put a pillow over their head while they're having sex.
Okay, so this is not on my list, but just based on that answer, would you therefore suggest that someone, when you said that they should be comfortable with where they're at in their journey figuring this out, would you suggest that someone work on that before they begin dating or, begin exploring that?
I would say you can do it before dating, you can do it while you're dating, you can do it, when you're married, like you can do it anytime. But I don't think that this diagnosis should be a shame marker for them.
Yes.
Right. This is how the cookie crumbles. These are the cards that were dealt.
Yeah.
And so you just want to inform your partner, hey, I have pelvic pain, but this is how I like to receive pleasure. And I'm working on it or I'm not working on it, and kind of work through it with that.
Okay. And in your experience, how successful are your patients generally in finding success, finding a sexual relationship that works when they do have something like vaginismus? This was a popular one.
So
is there a light at the end of the tunnel?
There is a light at the end of the tunnel, but I want to give people some insight into this. So people who have chronic pelvic pain or chronic sexual dysfunction, their partners usually develop some form of sexual dysfunction because their partner doesn't want to hurt them. Their partner is afraid to approach them, or they don't want them to feel pressure. So there's a lot of like performance anxiety, there's insecurity, there's hesitation. So then, I've gotten a question like that before where I had a guy reach out to me because he's like, UC, can you answer this question for Bourbon Tales? My wife had pelvic pain for many years and then no longer has it, but now I can't perform.
Oh.
And he was like, what do I do? I don't even know. Like, we've never had a situation where I didn't have to be cognizant of her pain. And now she's telling me I can, and I just don't know how to do that. So I think that everyone needs to give each other a lot of grace. So to start off with, that there's kind of a tug of war on both sides. But I do see people successfully negotiate this but the prerequisite is an open mind and a willingness to kind of go through that roller coaster, just like any other relationship.
Yeah.
But this condition it's not a handicap. I don't want people to think of it like that. It's an opportunity to understand and learn about your body and your sexuality in a way that actually can really improve your sexual communication and experience.
One just to keep it even for the men.
Yeah.
I figured. Do you have any male follow-ups in here?
There are a couple of. There's just one.
Nice. I mean, Dear Shandy's audience
like 98%
is primarily
female.
And I don't think the one guy who listens to Dear Shandy is going to talk about his erectile dysfunction. So, but my question is it's interesting because on the other side of the coin, erectile dysfunction is so easy to fix nowadays there's a million pills, like boner pills all over the place.
Do you agree with that?
No, I haven't finished the question.
Oh, okay.
But if you really want to get to the root of curing ED, I would imagine it's as or more complicated than the mental challenge of curing vaginismus.
Yes, yeah.
Vaginismus. Got it. So my question to you is, when a guy comes to you, which I'm sure guys do come to you with erectile dysfunction. Okay.
Oh yeah.
And that's probably the most common problem. I have two questions, but one is, do they come to you wanting to cure the root of it, or do they come just like, can you get me a prescription for Viagra?
No, they want their penis to work.
Okay. And and with men, is it the same ratio of mental to physical, or is it different?
If you're coming to me 40 and under with ED, we have to screen you for diabetes. We have to screen you for cardiovascular dysfunction first. Okay. Because you're young, there shouldn't be any physiological reason why this is happening. So they're going to do that first and make sure they roll that out. When you're under 40 with primary ED, there's most commonly, it's a psychological problem.
Mm-hmm. Got it. Okay.
Over 40, that's a whole different beast.
Right.
Because we're dealing with prostate issues. We're dealing with all these other
right. No, of course.
Yeah, that happen. So that's why it's like it's actually more direct with men over 40 than it is with men under 40.
Got it. And one last question. We're going to consolidate the male questions to like this 2-minute section.
Sure.
But just my second.
It's like the men's section in a department store,
like a lingerie store. So my second question is involving the pelvic floor with men. I'm assuming there are men who cannot orgasm, right?
Yeah.
That's a thing.
Or they have painful orgasms, painful ejaculation.
But as far as not being able to, I would imagine that being able to, have a pelvic floor that functions, lengthens and shortens properly would be necessary for that. So do you have men who come in with that problem?
Yes, I do.
Okay.
Yeah. And we do the same. It's a same intervention as women and vagina owners. It's simply just making sure they understand what their pelvic floor is doing at baseline, and then adjusting. So whether they have too much tone, relaxing. If they don't have enough tone, bulking that up.
So it's fair to say that you've seen everything, just on both sides.
I think that's pretty fair. I see trans patients or patients post-operatively after they've had gender affirmation surgery. I've seen, I've seen the gamut. It's a pretty cool job.
Wow.
Very, very cool. Okay. Postnatal issues.
Okay. Great.
Could you give us a brief overview of how giving birth affects the pelvic area?
Oh. I don't know why I don't know why I'm giggling. I think so when we have to remember that this queen has been carrying this child for 9 months, and all that weight and changes to the posture of the body puts a lot of stress on the pelvic floor itself. So it's kind of been in an elongated position for a long time, particularly in that 3rd trimester. So you have that. So from the pregnancy standpoint, now depending on the delivery and what has gone down in the delivery. So let's talk vaginal deliveries first. So if they had a really difficult vaginal delivery, if they labored for a long time, if they pushed for a long time, if they tore, right? So if you had, a grade 3 and a grade 4 tear is when you're basically tearing from vagina to rectum. They have to actually suture together your perineum again.
Ouch.
Does that make sense? Everything's open. So then they have to kind of close it, and they have to, because you have something called the perineal body that kind of is actually where your pelvic floor is attached. And that's between the anus and the vagina. And that
this is actually not uncommon.
No.
What I understand, right?
It's not common, but it's not
uncommon.
Right.
Okay. It's not rare.
Yeah, but it can be obliterated during delivery. And then if you had instrumentation, if forceps, vacuum, all of those things can happen. Even some people who have a grade 2 tear, which is still a tear, have significant pain because you could have compressed a nerve. We could have severed a nerve. So there are lots of things that can happen with that vaginal delivery. And then remember, with the C-section, you're not protected either, because that's a major abdominal surgery that's cutting through all the layers of the abdominal muscle wall. And you need that abdominal muscle wall to support your pelvis. Your pelvic floor is going to either undercompensate, it's going to overcompensate, or just kind of undercompensate after that surgery. So that's also a risk factor. So that's what happens during the pregnancy delivery process. So every person who gives birth should go to a pelvic floor physical therapist at least once to be screened. There are not enough of us out there to actually make that happen, but that actually should happen. So we can just at least evaluate you and just say, okay, you're good, girl. This is what I want you to do for the next 12 weeks or the next year. And to remember that the postpartum phase lasts about 2 years or until you stop breastfeeding and all that. So making sure they understand that there's a whole 4th trimester that occurs, which is called postpartum.
Okay.
Well, there goes our shot at having kids. Thank you.
I'm sorry. I mean, it's lovely and amazing and such a gift, and it's wonderful, and women are badasses. But I hope
they
I
are
answered that
badasses.
question. I hope I answered that question.
Oh, you answered that question. So, question.
Mm-hmm.
Is sex ever really the same? This one came up a lot.
So, no. I think yes and no. I truly can't answer that, actually, because I'm not in the body and in the relationship of all those other people. But based on my experience, people say that they get back to having sex and it either feels even better than before, about the same. Yeah, because they may have, and those are usually my patients who've gone through PT with me. So they're getting some counseling in terms of communication, and kind of it's almost an opportunity for them to revamp their sex life. And some of them really take that on. Now, depending on what goes on during that postpartum phase, it may be worse. They might have more pain, or they may not be able to feel things the same, or they feel like their sensation is gone, or it's harder to achieve orgasm. And that could be for a lot of reasons. It could be for what happened physically, or it could be what's going on. Their bandwidth is not what it used to be, right? Because you have a new baby, or you might have multiple children at home and a new baby, or there was problems in the relationship beforehand that now are getting exposed to a totally different level because you both are sleep deprived.
Mm-hmm.
And tired, and so
it's kind of the perfect storm. I mean, to pinpoint one physical aspect that makes sex less good after giving birth.
Yeah, I always tell people that if you're going into your pregnancy with it's fireworks, angels weeping type of sex, and you're communicating well and everything's good, and you manage your expectations about what sex life is going to look like after baby, and it's more fluid versus rigid. If you don't expect it's going to go just as it was before, and you say, we're going to find a new place that works for us, that mindset alone will help you. And it'll actually just kind of be a nice soft landing. And just okay, you know what? We're going to get it popping. It's going to feel different. It's probably going to feel better because we're going to do things different. We're going to approach it differently. We may not do it as much because we don't have time, or we may do it more. I don't know. Everyone's different. But that's the approach to look at.
Okay, you just answered one of my questions, but another one. Can doing pelvic exercises help prevent changes after birth, or is it all about postnatal care? Is there a point in doing pelvic exercises while you're pregnant?
There's definitely a point. Because remember, your pelvic floor is part of that pelvis. So the stronger your pelvic floor is, the stronger your abdominal muscles are. The stronger your glutes, your paraspinal muscles, all those are, you're going to do better after delivery, no matter what.
Incontinence, whether postnatal or incontinence in general. First of all, this might be such an ignorant question.
Please ask.
I'm sure the causes are different, whether it's postnatal or just general incontinence. Is the treatment similar? It's such a dumb question.
The treatment is similar, but that's a great question. Because you can have urinary incontinence. So the treatment for urinary incontinence is going to change depending on the population. So if I have a neuromuscular population, so patients with multiple sclerosis and Parkinson's, their treatment is going to be a little bit different than a postpartum patient.
Got it.
For incontinence. So that's where it's a great question. So yeah, it's going to be different. If a patient comes to me postpartum and they're saying that they're having leakage, I need to know what's going on. What happened with the delivery? What happened did you have incontinence before? Did you have pain before? Because if I'm not going to give someone Kegels if they have scar tissue and tearing from the delivery. I need to address those issues first. I need to address the pain first before I can deal with strengthening the muscles to get better support to the bladder and urethra. So it just depends. So I might have to do internal release, teach them how to do that themselves to make sure that scar tissue doesn't become a problem, or to address tight muscles, because a patient can leak with really tight muscles too. Because if I'm clenching my fist all day, do you think I can hold a fork?
No.
Right. right? Because I'm
point.
fatigued out. Like either my muscle's too tight, I can't release it, or the muscle's tired because it's been working overtime.
Too hard.
So,
Okay.
so that's why I said it depends on what I find. But I think pelvic floor strengthening is a gold standard treatment if that's appropriate based on the objective findings we get.
And when you say pelvic floor strengthening, are we basically talking Kegels?
Kegels, yeah. But
Pretty
also
much.
remember, most people don't do Kegels properly. So they're holding their breath, they're clenching their glutes, they're squeezing their toes, they're using their whole body to do a Kegel. Like I'm doing a Kegel right now, and I look like I have dead eyes, right? That's how it should look. But like if you're walking by and someone's like, I'm doing my Kegels, and you can see their shoulders moving and they're like, their body, I'm doing my Kegels, and they're like, bouncing on their chair. Yes. Like, nah, homie, you're not doing it right. Like, you need to fix that. All of that needs to be fixed.
Is it possible that if you are, I don't know, lifting your shoulders while doing your Kegels, that it's still better than nothing? Or is it like you're just doing it wrong? Period.
You're just doing it wrong.
Okay.
Yeah.
From the expert, you're doing it wrong. Okay. We're going to circle back to Kegels at the end.
Perfect.
Okay. Orgasming. If someone feels intense buildup during sex, with or without a partner, this came up a lot. The sense that they know they're close.
Okay.
And then either they just can't get there, it suddenly feels too sensitive, or it becomes uncomfortable. I guess some of that is psychological some of the time. I'm just wondering, I mean, I don't know, you tell me. And how often do you see that, and can exercising, strengthening the pelvic floor help with that?
Yeah, I see that all the time. So great question. Actually, a lot of people experience that, where they feel like it's almost like an orgasm glass ceiling. And they're like, it's like they're trying to get, and they can't get past the ceiling.
Yeah, she uses so many analogies, and I am living for it.
That's like it's horrifying.
Well, I mean, I can say I have been there.
I always tell people, so yes, pelvic floor strengthening can definitely be very helpful. But here's how I always tell people, this is like my little hack. So you can use the pelvic floor as a way to enhance your awareness of what's happening in your body. So instead of focusing on the orgasm and trying to achieve that orgasm, kind of use the pelvic floor to see if that can change the sensations that you're experiencing. It's almost like you're doing an elevator contraction. So I always tell people to think that you're squeezing and bring me to the second floor. Oh, third floor, fourth floor.
Wait, during sex?
Or during sex or masturbation. Right? So it's almost like you squeeze with 25% effort, then 50%, 75, 100. Because it should feel like it's coming up, 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 and then release, and then up, up, up. And almost is, and you can practice this when you're like massaging the clitoris, the vulva, whatever sexy time activity you're doing, and experiment with play, right? And kind of let that focus be, I want to see how this goes, or let me use my vibrator, let me not use my vibrator, let me see how this feels as I'm experimenting and playing with my pelvic floor in this way. And then boom, orgasm happens. Because when you shift your focus to kind of experiencing different sensations versus like I'm being kind of focused on goal-oriented sex or orgasm-oriented sex, it's just going to keep running from.
Yeah.
And this is a way to kind of low-key break that glass ceiling.
Low-key break.
And just kind of be able to kind of find a new path. Either you break the ceiling or you find a new way. And I always tell people, like, that's one way to do it is, doing Kegels, but kind of coordinated Kegels, and kind of used to focus on the pleasure-centric Kegels. Or for patients who have high tone, it may just simply be, we need to focus on muscle relaxation, right? Relaxing the muscle versus like kind of tense. Because some people kind of tense up their whole body to get the orgasm, or they feel like they really need like really, really intense sensation to get there, which they may need that, but they're kind of blocking blood flow from getting to that area if they're clenched all the time. And remember, arousal, orgasms, erections, all about the blood flow.
Okay, that's really interesting. So So what you would suggest for those people is truly to just experiment with Kegels, or like held Kegels or spurts of Kegels.
Yeah,
different.
like it's almost like graded Kegels. You can try that. That's just one technique out of 1,000. But you can do like a squeeze and squeeze and squeeze, and then woo, and then maybe start your vibration then, and then release. It's like, oh, that's a whole new sensation. But you also have to kind of be open to experimenting with that. And I think sometimes people have a lot of grief, and I know that sounds like a big word for this, but people do have a lot of grief about like their sexual performance and sensation and abilities and to achieve an orgasm or not. And sometimes they want to achieve it a certain way because they want to be like everybody else. And I'm like, let's let go of what they think it's supposed to look like.
I didn't have my first orgasm until I was 25. So I had a lot of the glass ceiling that you're talking about up until that point. So it speaks to me what you're saying.
Yeah.
My first orgasm, 7.
7?
Yeah.
Nice.
I was at the park climbing up a pole to get to somewhere, and it just boom.
And then you're like, holy shit,
I was with my grandmother, actually.
Really?
I told her too. She was like, she acted real weird. I remember she was.
I can imagine.
I don't want to talk. Like I was like, what are you talking about? I just discovered the most amazing thing in the world. Why don't you want to talk about this?
You know what's funny is we walked past that park and you pointed out that pole. Yeah, recently.
Yeah, I should put a plaque on it.
I also want to say one more thing about the orgasm thing is to really also examine, you know, again, I almost feel like annoyed with myself as I'm about to say this, but hang in there. Examine, you know, what your sexual philosophy and values are. If you do actually have a lot of shame around sex, it is going to mess with your ability to achieve an orgasm. And or it's going to mess with your ability to experience pleasure from an orgasm, because an orgasm and pleasure are not synonymous.
Mm-hmm.
Mm-hmm.
And so there are a lot of orgasms that are not pleasurable, right? But we want to be able to kind of think about that. And, you know, I always tell people to focus on their pleasure, but sometimes people don't know what that is. And so sometimes it might just be like, let's find your neutral and then go from there. So that's just my little bit.
And let's say you don't have an issue orgasming. Can doing Kegels, generally strengthening the pelvic floor, make your orgasms better?
Yeah. Oh, yeah.
Okay. Quick answer to that one. Moving on.
I also have a question for men. Okay. Another 10-second break. As men get older, and I've experienced this personally, not to like an extreme degree, but it's very noticeable. Orgasms just get less good.
Yeah.
And I've read something about something called like the ropes or something, where it's like this, how many contractions you have.
Oh, yeah.
Goes down. What is there anything for a man to do? I'm just asking for a friend, you know.
Asking for a friend. Kegels, like doing, I say, 10 to 15 Kegels a day keeps the pelvic floor physical therapist away. And do it different types. Like do some where you hold, do some where you're doing an elevator, do a quick flick, and do a regular contraction where you squeeze and lift, release, right? So for men, you want to imagine that you're tightening the anus and pulling the penis into your body, almost like a turtle's head going into a shell.
Got it. And can that count as saying I went to the gym, or is that not?
I say it's close. I would consider it like a gym warm-up.
Okay. All right. I'll take that.
The infamous G-spot.
Yes, queen. Yes.
Should all people with vaginas be able to have a G-spot orgasm, or some anatomy is just not built for it?
Okay, I'm just gonna keep it real with y'all. So the evidence is split. Some research scientists are like, what the hell are you talking about? That's full trash. And others say it exists. And so what I always tell my patients is that if you're experiencing a G-spot orgasm, go with it, right? And some people say, I want to find my G-spot. And again, it's going to have the similar response that I had with the orgasm question, where it's like, if you're just like having sex to find this illustrious G-spot, you're missing out.
Okay.
You're missing out. having G-spot oriented sex, especially if you haven't experienced something similar, or if a friend says they've had it and you're like, I want that to really just focus on experimenting with your body and your sexual pleasure and different ways to access that pleasure. And trust me, you will find spots that are hypersensitive to to touch, and you'll be like, ooh, okay. And it doesn't necessarily need to be inside the vagina.
Okay.
And this is another concept that I want people to understand, is that we have patients with spinal cord injury that are able to achieve orgasm, but they have partial sensation because the orgasm is achieved in the brain.
Mm-hmm.
The pleasure center is not the G-spot. The pleasure center is your brain. You can sensitize any part of your body to experience that pleasure.
So, yeah, I mean, it's crazy.
I just wanted to make sure that landed with the thud that it should land with.
Yeah, but I don't want to poo-poo on anyone's experience of what they've had in their body. If you're saying I have G-spot orgasm, I believe you.
Mm-hmm.
I believe you. I'm not saying it's not real, but I think from a physiological perspective, there's still high debate.
Okay, so don't necessarily go into every session seeking that out, because you might be setting yourself up for failure.
Exactly.
And to take that to an extreme, is it possible to have the exact same quality of orgasm from a vaginal versus a clitoral?
Yes.
Okay.
Yes. I think the issue, and it just depends, and it depends on the individual. So I think there are a couple of things. Number one, people who have a clitoral orgasm want the vaginal orgasm because they just want to experience it. Therefore, sometimes people come to me. I've had patients who say they have orgasm dysfunction because they haven't achieved a vaginal orgasm, but they can have a clitoral orgasm in their sleep. Right? And I'm like, but you don't have sexual, and the thing is, it's not for me to tell them they don't have sexual dysfunction, but it's for me to educate them and to manage their expectations moving forward and to teach them about their body and how they can explore their body. Now, some people, for just the sheer act of novelty, if they experience a vaginal orgasm, they're like, man, that was amazing, because it just felt different. It may have been a really great, the context was just right. They're like, I want that shit all day, every day. Get me more of that, please. Okay. And so then I say, okay, then chase that, right? So that's something where it's chase that, set that up, do it again and see what your body,
because it's possible.
Yes.
Yeah.
And so I think that when you're more open, when you're able to explore your body in a way that's not judgmental, that's not goal oriented, those pleasurable experiences will come, pending that you don't have any of the things that we talked about earlier.
This is your question, Andy.
It's my question. I had a question.
We had when we had the sex therapist on, this came up, and
this is a big
and
deal.
It went unanswered, and I was like, who's going to have our answer?
Now I'm gonna lay it on the table here. Whatever you say, I am going to agree is the definitive answer for this question. I am firm. Okay, you asked the question.
Oh my God, I'm nervous. Okay,
yeah.
ready.
Well, I just want to make sure everyone knows that I'm not arguing with you. If you say that whatever the answer is, it goes against my theory, I'm going to accept it once and for all.
Demystify squirting. What is it?
Okay, great question. And I just answered this in Bourbon Tales 2 weeks ago or 3 weeks ago. Anyway. So
I confess I watched it, so I already know what she's gonna say.
Oh, you didn't tell me.
Yeah, I didn't want to spoil it for you, but I've already scoped it. Everyone should follow your Instagram, UC Logic, because it's very educational.
Should I tell her my theory before she goes into hers?
No, because people are okay, sure, but people are very offended by Andy's theory last time.
Maybe I shouldn't.
But you can tell her.
I think, and I will accept being completely wrong, that it's mostly urine.
Okay. So
that's it.
Okay. Well, a lot. So that is actually incorrect. And
damn it.
But I think it was. I think it's a very common question. So there is such thing. I'm just going to clarify. There's such thing as coital incontinence. So women who have urinary incontinence with orgasm or sexual arousal. Okay. So, but that's not this. So what we know to be true is that there can be there is a little bit of urine in it, but there's also, kind of lubrication and some prostate type qualities that can come out of the vagina for a lot of women. But squirting is not, there's still have to be debate on this. There's no physiological proof that that's a thing. Though some women may have that, they may squirt, but not the volume that you're seeing in porn, where it's like just shooting across, like where it's like, right? Some women can squirt, but it's not going to be like a gallon amount. And some people.
But what if it is a gallon amount?
Yeah. So in Andy's experience, it has been a gallon amount, and so he just
I lied. I'm going to the mat with you.
So in that case, that probably was some coital incontinence.
Okay. Interesting. Okay. So in other words, if you have like porn style squirting, it's likely coital incontinence. Yes. Interesting.
But most likely like, a combination.
A combination of the two. So I'm not saying that, because squirting is not incontinence.
Okay.
Yeah.
So that's a separate.
Because I was specifically referring to porn style squirting.
Yeah. So like and that's what we're saying is like porn style squirting. Like there's no organ in the system that can hold that amount of fluid.
That's what I was.
Okay. So that's what he was saying last time, but people got upset. But
I want to clarify that I'm not talking about some like little dainty squirting. I'm talking about the full on like.
Yeah, and so squirting. In that case, the only organ system that can hold that much volume is the bladder. Mm-hmm. And so in that case, that most likely that person was having a coital incontinence episode, and squirting or I forget what the other way we describe it, but squirting is not that.
Okay.
It's not that. It's like, I think they did there was a research study, and I don't want to quote the percentage, but it was a small amount of urine, like a small amount. It wasn't all urine. That's not it.
That makes sense. Thank you. That was
You're welcome.
Enlightening.
And actually on that note, you can squirt without orgasming. Mm-hmm. Correct? Yes, that's what I thought.
Oh.
All right. Last question. It's a two-parter. What's a good basic pelvic floor exercise that that would benefit anyone listening to this conversation? And then from there, any equipment, toys, apps, just give us the homework that we can all walk away from, men and women.
Okay, so we're going to just talk about pelvic health from a general health perspective. And I'll tell you what I do on the daily, if that helps.
Yeah. I want to know.
Not too much TMI or anything like that.
What does the expert do?
The expert, what I do is similar to what I was saying before, is I pick a time every day, either first thing in the morning or in the evening. And I do 10 pelvic floor contractions. So for me, I'll start with doing a hold. So I'll squeeze and hold for 10 seconds, and then I rest for 10 seconds. So I repeat that 5 times. Then I'm going to do my elevator. So I might squeeze and just go up, 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 down, 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 up, 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 down, down, down.
Are we both doing it right now?
I'm doing it right now.
I'm doing it too.
Yeah. And I do that 5 times, and then that's it. So that's what I do. And then some days I might do like all hold. Some day I'll do quick flicks. So squeeze and lift, release, squeeze and lift, release, squeeze and lift, release, squeeze and lift, release.
What's the, just for my friend, what's the timing in between each of these things?
Sure. So I just do one set of 10, but sometimes I divvy it. So I might do 5. So I'll do like I said, like 5 quick flicks. So like squeeze and release, squeeze and release. So that's a quick flick. Then I rest for 30 seconds. Then I'll do another set of 5 of a different type of contraction.
And would you say it's the same for men and women?
It's like CrossFit.
Yes.
All genders, exercises.
All genital packages are good to go with this. Now, the only caveat is I'm saying this as a general exercise. If you have pain, if you have constipation, if you have difficulty emptying your bladder, things like that, don't do this without being screened by a healthcare provider first. And if you have problems or if you start experiencing pain when you do this, just go ahead and stop and see someone.
Any equipment, toys, or apps?
I like toys. So I like toys because they give you feedback. So toys that you can insert into the anus or into the vagina, so you can squeeze around and feel your muscles working around that actually helps you kind of understand, that I'm getting stronger. I can feel that. You can even use a penis, right? You could do all types of things. So that would be my best recommendation, just if you want to change things up. You can also do your exercises while masturbating. So if you're using a toy, external toy or internal toy, that can also be a good thing to use while you're doing your Kegels. But there are no apps that I would say consistently get, because I've tried a lot of apps with some of my patients and I've gotten a lot of mixed feedback. So there's nothing that's overwhelmingly, yes, this is amazing.
But toys that get the thumbs up.
Yes.
From Dr. UC.
Yes.
And okay, and are there any?
I was about to wrap. What is it now?
No, I got an important question. Are there any secret weapon? I know you have them, so don't be shy. Are there any like secret weapon, male and woman, female and male versions of how to like just cheat an orgasm? Just like the real, like some people, like some people just stick a finger up someone's butt and like.
I mean,
okay. No, you know what I'm talking about.
I know what you're talking about.
You know what I'm talking about.
So for men, I will say this, that prostate stimulation gives a way stronger orgasm and muscle contraction, powerful muscle contraction than, stimulation of the penis alone.
And what's the best way to get
to access the prostate?
Mm-hmm.
Yeah, you insert your finger. So let's say you're laying on your side, your right side, you're going to insert the finger into the rectum all the way and then almost kind of do like a come hither movement with your index finger. So you're going to be feeling that prostate and you kind of massage it as you're kind of stroking the penis. So that can be helpful. You just have to play with pressure. You just have to play with the pressure and the sensitivity, and everyone's a little bit different.
And for women?
Yeah.
So for women, I would say one of the things is a lot of women direct stimulation can get a little bit sensitive over time. So I say that a real hack is to sandwich the clitoris with the vulva and do like this circle motion as you insert the finger into the vagina. If the person does not have pain as you're taking notes, and actually do a similar motion. And everyone says that that's the G-spot motion, but it's really just kind of getting that those periurethral tissues are really sensitive. And they're also kind of attached to the clitoral legs. And massaging that area, that come hither, or you can come along the sides. Because remember, the clitoris is like a wishbone.
Mm-hmm.
Yeah,
so it has legs.
We learned that.
It has legs along the sides. So you can actually, like, if you don't like that sensation, I call it 12 o'clock where the urethra is, then go to like 3 o'clock or 9 o'clock because the legs of the clitoris are there. And you can kind of massage and still do that hey, as you massage.
Do you ever, you should like do live coaching sessions.
She does have on her Instagram, she's got it all.
No, I mean, you should be there like a coach. Be like, you got this. No,
you got this.
You got this.
Like,
come on,
stop.
let's do it.
No.
How did we do this in the gym? How did we do this? That's not how we did it.
That's not how I coached you, right? It's funny. I am working on some stuff. Like last year I was going to do something and then I actually just scrapped it because I didn't feel like with my focus group, it didn't work. And I was like, okay, I'm going to start from scratch. But I am going to do something for postpartum women to get their sexy back. And, it's going to be like this, like coaching and being like, I do this specifically and see how that feels, that type of thing. So we'll see how it goes.
The world needs that.
Well, we'll start with them. We'll start with them, but then I'm gonna spread the love to all of the peoples.
There was a lot of love that you just spread with us. I've got to say that was enlightening. That last bit reminded me of like those Cosmo articles I used to read when I was in high school. But it's like it's what you wanted that article to be.
Oh yeah, exactly. Not like tiptoeing around, just right into it.
Yeah.
Oh yeah.
Like right in and up.
Yeah. I was like,
rub.
nope, this is how you do it.
Yeah. Uchenna.
Your lucky boyfriend. That's all I gotta say. I hope they know what they got.
Uchenna, that was like, I had high expectations. You just surpassed them all. That was
fantastic.
Enlightening.
Oh, really?
Fantastic.
I'm so glad. I was like, I hope I'm answering these questions all right.
You did good.
No, that was really next level. Like we went more than half an hour over time, and I'm sorry for keeping you so long, but it's really, we like to go with the flow and we just couldn't stop.
So it's my pleasure. This was really fun. Like I love answering these questions because I just want people to have good information. So this has been great.
So where, if my friend has his problems, where does he go to, what does he do? Tell people what they do to get what you have to offer.
Absolutely. So if you want to work with me one-on-one, because I do see clients, couples, and individuals, you can go to my website, www.uclogic.com, and just fill out the form, and my assistant will get back to you and get you scheduled. And then we could work together. You could also DM me on Instagram at UCLogic or Facebook. And I'm also on Twitter.
Awesome.
I'm speechless. Thank you so much, Uchenna. What a great episode.
Yeah, thank you. Really thank you.
Yeah.
Oh, my gosh.
You've answered everything, and just
everything.
Even things that I didn't think not that I didn't think you could, but just things that I wouldn't have thought would be answered in this conversation. Does that make sense?
Yes, absolutely. I'm super honored.
Thank you so much for joining us.
Thank you.
Well, thank you.
We'll be following you.
All
Thank
right.
you. Have a great night.
You
Thank
too.
you, Uchenna.
Bye.
Bye.
Oh, yeah. Wow. That was a lot.
Hey, that was amazing.
It was a lot. That was a lot of amazing.
A lot of amazing. Oof. She answered things that, like, I knew that she would have a lot to offer, but I love how specific she got. Like, I gave you a hard time for asking another question when I wanted to wrap, but just the specificity of, like, get on your side, put your finger in the anus, and do this. Like, people need that. People don't talk about it enough. They're like, oh yeah, stimulate the prostate.
No, that was, I knew she was going to deliver.
Yeah.
I knew it.
Yeah. She was fantastic.
She's probably got a million tricks. She could probably write a book just on that.
I love her, just sort of the open, accepting vibe. Mm-hmm. It's like, come to me, let's talk about it. Let's figure it out. It's just it's the right energy for what she does.
She's got
There's so much anxiety about
like sexual problem bedside manner. You couldn't be better.
Sexual problem bedside manner, exactly.
Yeah. She was just like an angel.
Yes. I have nothing to add. She said everything that needed to be said.
Yeah.
And we're over time.
Yeah.
So shall we wrap?
We shall wrap.
If you enjoyed what you heard today, you can keep Dear Shandy in business by liking, subscribing, hitting the notification bell, following us on Instagram, leaving us iTunes reviews and ratings. We always love many stars.
Mm-hmm. We do. We like the most amount of stars,
we like the most amount of stars, which is
it's always 5.
5 stars, yes. Yeah. Okay, and anything else? Oh, and tell your friends.
Yeah, tell your friends.
And all the things that you would do to keep a podcast like ours in business. Mm-hmm. And on that note, thanks so much for tuning in, guys, and we'll see you next time on Dear Shandy. Bye.